working in Bergamo. I am in charge of this department, ophthalmology department in Bergamo. We are about 23, 24 ophthalmologists. And so mainly our activity is in between the two hospitals in Bergamo. So at the moment, the situation is in Bergamo, as you know, is quite tough. In Italy, we have about right now 64,000 cases positive for COVID-19. 6,000 people already, died for COVID-19, and we have about 7,000 death recovery. So the situation is still growing a lot in terms of positive, and the worst part was since 3 weeks, because until the end of February was under control, just few cases, but then, the numbers were growing, 1,000–2,000 cases per day, even more. And so the situation right now is still not under control, and we didn't reach, the peak of the, disease yet. So we are trying, to do, the best that we can do in order, to close everything up. That means also, our activity in our department. So if you want to start with some question, otherwise I can carry on, just, sharing my experience. So let me know what you prefer.
Okay, it's perfect. If you can tell us how, or explain us, how do you start with the measurements at your hospital? What did you do first?
Okay, so the point is probably everything started since, small places around Bergamo, okay? And, the action that, have been done at that moment were not strong enough. So that's why the spreading was so bad then. This is an hypothesis, but actually what we are doing is, we are following, these routes. First of all, we have a very efficient triage in the hospital. So that means is in the main entrance of the hospital or in a tent that's just next to the entrance. And what we are doing, we are measuring the temperature. If the temperature is, more than 37.8 Celsius degree, and the patient is still, good, healthy, we send back the patient home, and we ask the patient to call the number provided, for the, COVID-19. And if the patient is has already got severe symptoms, we directly ask to the staff that have been trained for this activity to get the patient and to try to bring them in COVID area. Okay. So, but for regarding the ophthalmology activity, so if the patient get as a temperature that is less than 37.8 Celsius degree, the staff that is always not administrative staff is health staff worker. So they give mask that is surgical mask, and they try to get the hands hygiene for hands, and then they let them to get in the hospital, and they have always to have the mask on all the time. And we are reducing the elective activity. That means visit, clinics, and surgery. We are just the triage works also, calling the patient before and asking if they have really an acute symptoms, eye symptoms, to get in the hospital. That means for mainly the patient cannot see like for a macula, a retinal detachment, or for like acute glaucoma. We are not doing even elective surgery for transplant, cornea transplant. We are just doing, trauma, retinal detachment, and acute glaucoma. So right now in the main hospital where that is a COVID hospital, we are not doing even ophthalmology at all. Okay, but there are some places that are, let's say, COVID free. At least there is not word for COVID, where in our region we are doing these ophthalmology cases. Otherwise, we are stopping all ophthalmology activity.
Do you have any kind of telemedicine or triage by phone with the patients?
Yeah, we have, as I was saying before, we have a triage also, by phone, asking if the patient really is, in the last few days is just losing the vision, like for a retinal detachment, or as a pain, like for an acute glaucoma. Otherwise, the triage just asks the patient if there is anything new that is happening, or it's just a visit because, they want to check if everything is going well. So we are doing the triage, on call first, and then like systemic triage when the patient is getting inside hospital. But otherwise, we call all the patients and we just telling them to stay back home.
So when was the last cornea transplantation you performed? And the COVID was already described in Italy. And if you did some cornea transplantation, are you having any special follow up to this kind of patients?
Okay, so we did last surgery, I think was 26th of February, and there were just a few cases. I think were 3 or 4, let's say, that were it was 23 were less than 100 cases, okay, and was 23rd of February, and we did a few cases, cornea cases, and also retinal cases, okay, and then just for that patient that we really need to see, we organized just a few clinics, in the next few days. And then, if the patient was fine, we didn't ask to, get back. Yeah. But still, we are doing some clinic, okay? Like in case we have, the patient that is complaining for, something that is going wrong and he doesn't know really what to see. But still, the patient has to go through, all these steps before.
So Mario, I don't know if I understood it well, but you guys have for ophthalmology attention. You have a special hospital or a special place to see patients with COVID positive, and other to take care of patients without COVID. It's like that.
Yeah, because the main point is recommended splitting the staff into segregated teams, so they don't have to work, together. They don't have to have any kind of interaction. So that's why we try, to have, a different teams and different hospital. Otherwise, if we are doing, the surgery and we are treating the patient in the same hospital where there are also COVID, we think that is not safe for the patient itself, but also for the staff, because they can are in contact each other.
And before you perform surgery with the patient, you test them for COVID,
we are testing the patient, just the patient that has to go for surgery. Otherwise, we are not testing the patient for clinic.
What about the medical team?
The medical team, has been tested so far if you have symptoms. Otherwise, they are not testing you at all. So we are not doing a test for, now the situation is changing a bit. So, but the situation is really, up to date, every day, because, sometimes they start thinking that it's better to do the test to, all the medical staff. And the day after, the situation can change. But at the moment, we have not been tested, until you have or, fever or dyspnea or anosmia.
Okay, any of the ophthalmologists has been called for the first line at the hospital or not?
Our colleague, one of our colleague, died just yesterday, was an ophthalmology, and he was not working. We don't know, how he, get this, infection. He was working until the end of February, but really we don't know if it was, because it was in the hospital or because, was outside of the hospital. Because since the end of February, we closed everything. So,
how old was your colleague?
How old was 70, 60,
okay.
And 69, 70. And the point is that we closed by the end, at the end of February, everything. So now it's 24th of March. So we don't know really if, the infection was because he was working in the hospital or was outside. Because I am still working in the hospital because I'm also helping, other, activity.
Vito Romano from Liverpool, your brother. Thank you, Vito, for joining us. On behalf of the Argentinian Council of Ophthalmology. So can you describe your situation right now and like the difference between the situation your brother is telling us?
Yes. So the situation for us is a little bit different because we know what's happening in Italy, and we can learn from what they did and what they're doing. So at the moment in UK there are around 8,000 patients and positive, and they died around more than 400 people. This means we believe that this number are underestimation of the real number, because there are most people that have symptoms and they are sick at home, and they don't be tested. They test just people that they go in the hospital and need to be admitted. Otherwise, they don't test you. The same thing happened also for the medical, for the healthcare staff. So we have in our department, we have 200 people that work between doctor and staff, nurses and administrative staff. And we have around 11 people sick at the moment. Sick means that they are home for 14 days, but this means that they are not being tested, but they've been asked to stay home for 14 days if you have fever or cough. Persistent cough. Some of them we know from them that they have anosmia. Some is a shivering and a temperature, and so far no one of them is been hospital in the hospital in terms of admitted. We had in the same our hospital, we had other doctor. Instead they had a problem and they are admitted. The question that we have at the moment that in the beginning we were using some precaution that clearly was not enough, because these people get get problem or get, we didn't want to get fever. We don't know how they got it, but that was the problem. So we are following a little bit more close what the Italian people suggest. And at the moment, it's recommended to wear a mask to see the patient, to wear the patient, and the patient himself need to see a mask. We reduce at the minimal the outpatient clinic. The minimal means from a cornea point of view, you see patient just with the perforation and microbial keratitis. If you did a surgery, like you were asking before, that you did a surgery on corneal transplant, you see patients that have 6 weeks after surgery. After that, you try to delay. If, of course, you try to minimize everything. Say if you stop all the elective procedure surgically as well, and not transplant anymore until everything is sorted.
What kind of mask are you using at the hospital?
So to see patient, so there is a, as Mario said, there is a triage in front of the hospital. They ask you questionnaire, and if you are, let's say, no suspect, you can walk in with the mask and after clean your hand. And
do you have N95 or which kind of mask?
No, surgical mask.
Okay.
It's not the best, but at the moment there is not enough mask to wear an FFP3. So these are the best mask that it's just used for, the best mask, the one that filter more particle, is been used just for people that they do contact with the COVID patient positive. And we don't think that at the moment COVID patient need to be seen by us, because the eye is not at the moment an issue for them. Even if they have a conjunctivitis, probably the conjunctivitis can be sorted by himself or just using some artificial tears. I don't think we needed to see them. We are more worried of people that are asymptomatic and they can be carrier. And we are more worried that this can be doctor or patient. And for this reason, we are, all the patients that they come in, that really are very few, usually are 45 minutes apart, the patient. I tell you why they are 45 minutes apart. So before they come to the clinic, we see the day before or 2 days before, we see the clinic, and we triage the patient in terms of, we see which patient can be postponed, which patient can be just called home, we call them, and which patient instead that are, let's say, high risk, need to be seen. And this patient need to be seen probably over a session that is 4-hour session in the morning or in the afternoon, can be 45 minutes apart. In this way, the waiting area is never packed. And the other things that we do, we use a mask. I told you we use a mask. We have a breathe shield on the slit lamp. No, we wear ourselves as a mask as well. Also, it's recommended to use scrubs for the healthcare, because you don't want to bring home anything that is dirty with the possible virus. And if you want to wear your own clothes, it's recommended to remove before to go home, put in a plastic bag, and then wash it. The normal washing should be fine. It's recommended probably 60 degrees. Other things you want to know about surgery, as I said, it's just retinal detachment and perforation is going ahead. Also glaucoma surgery, people that have a high risk that they need a trabeculectomy, and they are doing some, but it's very few. Unfortunately, we don't have the good things that they are planning to have. They did in Milan, so there is not a hospital COVID positive and a hospital, let's say, without COVID. But we all do in the same hospital, but we try to minimize everything. For example, we minimize also the doctor. The doctor go in the hospital just when they need to see this patient, and release all the other time they stay home.
Okay, looking to the future, what do you think about iBanking? And are you thinking in performing PCR for the future donors?
So the donors are ready. So we use tissue from England Venice and Monza, so 2 banks from Italy, and we are already using tissue from them. In the last few weeks, we already did it, even it was outbreak, because it's a mandatory for them to check the patient was coronavirus negative. So they do the test and a PCR, and they attach in the letter that they sent to us that this donor is come from coronavirus negative. It's been true that they notice a reduction of the donors because there is a problem that the people doesn't want to go to retrieval. 2, because if they are suspect, they don't want the people that they don't want to retrieve, but they are suspect also. There is a reduction of the donors. So at the moment, they still have the donors, but a little bit less, in Italy at least. In UK, at the moment, they're not testing for coronavirus. I think for a regulatory point of view, will come soon.
So do you think that it's going to be necessary for you as an ophthalmologist to be at the front line in the UK?
So frontline, if you think frontline means to see patient ophthalmologists, patient that have eye disease, we see them, and we see as we as a consultant, we see them. All the registrar and below the registrar are taken away from us, and they go in turn in the ward to see to help the others. And we as a consultant, we look after our department.
Perfect. So Vito, do you have any message to the community of ophthalmologists to finish this?
The message is to reduce as much as you can every kind of a clinic, because reduce to go in the hospital because it's always risky. To wash your hand, put scrubs, put goggles because it's important. Put mask, the surgical mask at least. Triage the patient, and just wash your clean your slit lamp as much as possible. It's also important, very important. All the desk area is very important, that because you never know if anyone else can use the same typing or something with the hand they're not clean. It seems a little bit too much, but it's the minimum that because it's very easy apparently that we can spread. There is at the moment there is no big study to understand which is how many, so a carrier, so an asymptomatic carrier, how many people can infect, and this is the most worried things at the moment for us.
Okay, Mario, do you have any final message to give us?
So, I mean, in Italy, the situation at the beginning, by the end of February, looked under control, but the situation get worse immediately. So really, try to keep, everything, the best that you can do, really. And sometimes at the beginning it seems too much, but it's not too much because a lot of people are dying. So the triage is very important. The triage, with the phone call is even more important to leave the patient back home. So really, we really need to minimize everything, because also the age-related macular degeneration, doing injection, because it seems to be really important, but the age of the population is very old. So, so even the patient, we treat with the, injection every month, and then, can really happen that can get, the virus, and then, for them will be very tough to get out. So really, we need to avoid as much as we can the contact of the patient around, really. We are asking to the ophthalmologists, not just to administrative, peer staff, to call the people, just asking the symptoms, and they try to understand according to the history, if that symptoms are really something, emergency or not. This is what we are doing right now. And what we are asking just to, we we'll call back, we will tell them that we will call back you in 3 months. And then, you know, we will rearrange everything.
Okay, thank you.
For our point, here we are not prepared for telemedicine. What we are trying, in addition to the call, because we think that probably this will last at least 3 months, we'll try to have access from the chart, the patient notes from home, in this way to release the doctor even to go to the hospital. So go to the hospital just to see the minimum, to be the minimal time and to see just the minimal amount of patient.
Perfect. Okay, thank you very much to you both. We appreciate your time. The best wishes for both countries.
Thank you.